Welcome, everybody, to the first Berkeley Public Health Alumni Association, PHAA for short, Professional Development Webinar of the Year. My name is Alice Chu, and I'm the co-president of PHAA. PHAA consists of 24 board of director volunteers who promote diversity and scholarship, events and networking, and professional development for current students and alumni. And if you are interested in receiving more information about our events, please sign up at the URL site below. Okay, today's upskilling webinar was spearheaded by our executive and professional development subcommittees to continue the school's mission of developing public health change makers. So misinformation and disinformation are timely topics, as evidenced by the impact of social media and networks and the internet on educating the public on dangerous preventative tactics and treatments for COVID and resisting vaccinations. But regardless of what topic, evidence-based health education is necessary for patient activation in terms of managing one's health and also individuals' decision-making in health. But how can we combat misinformation, whether it comes from Aunt Jenny or our colleagues? So what we have here today is Dr. Sara Gorman and Professor David Scales, who are part of the C-suite executive team of Critica, Inc. It is a nonprofit organization whose mission is to improve the public understanding of scientific consensus, counteract misstatements about health and science, and promote the use of scientific evidence in public policy making. And we will hear from these experts on the basis of misinformation, how it influences people, and what are some practical approaches to counteract as public health practitioners. In terms of logistics, Q&A will occur in two parts, after session 1 and after session 2. Please type your questions into the Q&A box below. My colleague, Dr. Annie Chang, who leads the Professional Development Committee, will be moderating the questions. Sara and David, thank you so much for sharing your evening with us. Over to you.
Thank you so much for having us. I'm going to go ahead and share my screen and get started. So hopefully everyone can see this slideshow. Great. Thanks for the thumbs up. So we're here to talk to you today about more than misinformed, improving public health information environments. So we will get to who we are a little bit in a minute and a little bit more about Critica, but I wanted to just comment on the title here. What we're really trying to do today is talk about the way that misinformation has been traditionally conceived in the field and some of the new ways, based on our extensive research and experience with misinformation, that we feel that this concept needs to be thought about to really help us get a better handle on what to do about it. So all of the sort of necessary statements at the beginning, we have no conflicts of interest to report. Dave has been a consultant for the U.S. Office of the Surgeon General, and our work has been generously supported by the Robert Wood Johnson Foundation, and the views here do not necessarily reflect those of the foundation. We have an amazing team of people with us at Critica, as well as a number of collaborators. They're not all listed here, across many institutions and coming from all parts of the country, as well as internationally now. And so we just wanted to list some of them here and acknowledge that there are many people who went into thinking about some of these ideas. So here's a little bit about what we're going to cover today. I'm going to very briefly define misinformation. There are different definitions out there, and there's often some confusion about the difference between misinformation and disinformation. So I'll just go into that briefly, just to give us, a common definition for what we're talking about. And then I'm going to talk a little bit about how health communication has changed. And a lot of you will, I'm sure, recognize what I'm talking about immediately. But some of the ways that social media has contributed to the changes in health communication, some of the ways the pandemic has contributed to a change in health communication, and some of the ways that we feel that, as public health practitioners, as I am one of them, are not always keeping up with some of these changes. And then we're going to present an idea about an environmental model of information and talk about exposure to misinformation, what that means, looking at this from sort of an environmental health point of view, and why that model will help us get both a better handle on what is going on with misinformation, but a much better feeling for where and when we should intervene. And then Dave especially will talk about what we have conceptualized as a way of addressing unhealthy information environments in a holistic way. And he'll talk a lot about Critica's intervention, which is to train people we call infodemiologists, which is a nice combination of information and epidemiologists. And we're training a new cohort of them now. And so Dave will give you a lot more details about how that works. So before I go into some of that content, as I said, I wanted to just give you a brief definition of some of the forms of information that is not correct. So here you see that it's really an event diagram, and this is important to notice that there are overlaps, for example, between misinformation and disinformation. A lot of the time, because misinformation is defined as something that's false or misleading, where the intention is not really meant to be harmful. So somebody may accidentally share incorrect information, but they're not intentionally trying to harm anyone or spread things that are outright lies. Whereas disinformation is deliberately manipulated false content, where again, the intention is to actually deceive. And the problem here is that intentionality is very difficult to actually understand or ascertain at any given moment. So we don't always know when we see incorrect information on the internet, whether it is in reality misinformation or disinformation. So that's just important to keep in mind, that solutions to issues around misinformation have to take disinformation into account as well, and vice versa, because there is actually a good deal of overlap, or just we don't have enough knowledge to figure out where these things are coming from sometimes. And then there is also malinformation, which is sort of a more extreme version, harassment, hate speech, language that is extremely fighting language, or something that is meant to be incredibly harmful. So I will leave you with a quote from a book by Harry Frankfurt that's called I'll say BS here because I don't want to offend anyone. So these BSers seek to convey a certain impression of themselves without being concerned about whether anything at all is true. They quietly change the rules governing their end of the conversation so that claims about truth and falsity are irrelevant. So in this quote, you're seeing that people are making statements, but they're not concerned necessarily about truth or not truth. And I've seen this come up a lot in the literature, that human beings are not sort of made to look for accuracy, but they want to look for something that is meaningful to them. So this is not necessarily people's priority when they share on the internet. And sometimes it's a bad intention, and sometimes there's really no motive that we can discern. So with that being said, what is sort of the official working definition of health misinformation that we have right now? So health information is false, inaccurate, misleading information on health concerns. And so it has to be based on the information that we have at the moment. And that's important because obviously with something like COVID-19, there were a lot of things that may have been inaccurate to a degree that were shared early on that were sort of corrected later because we just didn't know everything about the pandemic. That wouldn't have been misinformation. It has to be based on what we know at the time, whether that information is false, inaccurate, and misleading. And I did want to point out here, I'm actually working on a new book on medical mistrust and conspiracy theories. And I've done dozens of interviews with people who either themselves are distrustful of the medical system and the healthcare system, or have family members and close friends who are. And I've heard many, many stories about people who have literally died from being really extreme about misinformation and really falling into a lot of misinformed beliefs about health and medicine, which I'm sure I don't have to tell you. But the idea here is that it's consequential, it has real health outcome meaning, and that there are real consequences in the real world to misinformation. So I'll pause here a little bit from the content and talk a little bit about Critica, and I'll also let Dave talk a little bit about his path to getting interested in this area of medical misinformation. So Critica sort of started with a book that I published with my father actually in 2016 called Denying to the Grave. And in that book, we looked at the psychological reasons behind science denial. And at the time, so remember, I started writing this book in about 2013, so that's 10 years ago. At the time, I was really, really interested in the anti-vaccine movement, especially around childhood vaccines, and got very interested in what the psychological and social predispositions were behind believing some of these ideas. Because one thing I really noticed right away was that a lot of the people who believed these ideas were not uneducated or didn't have any access at all to good information, but there was some other motivator that was causing them not to sort of be able to accept the evidence. And so that's what this book was really about. But it also went into some of the potential ideas for ways that we could mitigate some of the science denial and misinformation. And at the time, in around 2017, people started asking me, what are you going to actually do about this? And so we decided to found Critica at that time. And you heard a little bit about the mission. We want to improve understanding of scientific consensus, counteract misinformation about science and health, and increase the use of scientific evidence in public policymaking. And that's really across various areas, including things like energy and climate. We've been really focused on COVID vaccine misinformation and now reproductive health as well in the past several years. And we are looking at other areas where we see a lot of misinformation cropping up, especially around things like long COVID and anticipating new vaccines like the malaria vaccine. So we also publish regularly on the site, and we do trainings, which I'll talk about in a minute, for organizations that are interested in learning more about how they can counteract misinformation in their sphere of whatever they work on within science. So we've trained people in various areas, not just the health sciences. And maybe I'll let Dave talk about a little bit about his path here.
Just briefly, so my background is in medicine. I'm an internal medicine physician, but also a sociologist. But I experimented with kind of different ways to reach the public. And I had studied a little bit of what social scientists would call contested illnesses during my sociology degree. But I had an opportunity while I was a resident to do some electives in medical journalism that I did with WBUR, and post-residency, I was briefly a special correspondent with WBUR, which is an NPR affiliate in Boston, where I did some reporting about Lyme disease and a stark divide. And Sarah, if you want to bring up some of the other kind of reporting that I did. And so I looked at this both in Boston and got a small grant to do some reporting on the manifestation of a controversy around Lyme disease in France as well, and really started to see some of the dynamics of how misinformation works and how it leads to polarization even around specific diseases. Because fundamentally, there is an international consensus on what Lyme disease is and how to treat it. There's a penumbra of uncertainty around certain aspects of the disease, especially whether or not people can have symptoms after treatment. And within that uncertainty, there's a community of people who identify as suffering from what they would call chronic Lyme disease. And they seek care from what they describe as Lyme literate physicians. And that has led to polarization about what types of treatment, with people seeking out very specific types of treatment And this type of phenomenon is one that I've started to see in a number of different areas as well. And so this is the pathway that led me to misinformation, and it's something that we're continuing to follow as we're currently even writing grants about trying to look at long COVID under a similar framework. So that's my pathway to studying misinformation.
Thanks, Dave. So as I mentioned a minute ago, we do trainings. We've done several for the Navajo Nation, for the Society of General Internal Medicine, and for the American Physical Society, among others. We've done some trainings for the World Health Organization and a few other bodies as well. And I will say so David will explain a little bit more about how we train our infodemiologists and what the methods are there, but we do train organizations on sort of a more shorter basis to learn some of the techniques that we train our infodemiologists on, in terms of using usually motivational interviewing to have conversations with people who are hesitant or resistant to certain scientific ideas or ideas in health. And so with the American Physical Society, just to take one example, they actually, after training with us, launched a whole preventing science misinformation and building trust in science sort of channel of their organization that has a number of trainings, other trainings under it, and is a whole initiative. And we've done several trainings with them, and we know that their members are actively using, even casually in their daily lives, a lot of the methodologies that we taught them and finding success there. So that's just sort of an example of some of the work that we do outside of the everyday research that we're doing. So I wanted to talk a little bit about sort of the way that, as I said, the way that health communication has changed over the years. So this is a network map of Twitter conversations from people talking about vaccines, and a specific state bill actually in California that was in 2015. I'm sure some of you remember, about the ending the personal belief exemptions to the childhood vaccination requirements. And so we see clusters of different interest groups in this map. So each bubble is a Twitter user, and the size has to do with how many followers and how influential they are. And the connections between them has to do with how much they are talking to each other. So you might see that some of the colors are overlapping and sort of running into each other. So I'll tell you what they are. The orange is the autism community. The pink is the anti-vaccine community. The blue is kind of a smaller cluster of a medical freedom movement. And the teal is the Tea Party. And then all the way over to the right, in the sort of darker green, is the pro-vaccine public health community. And so the reason why I wanted to show you this map is because we can see there's this sort of networked communication. There are a lot of groups that are communicating back and forth with each other already about these topics. And the public health community is there, but they're not really entrenched in these conversations. And they're still sort of on the side of what's going on with these conversations. And so this has a lot to do with social media. Of course, we're looking at Twitter and the way in which these networks have sort of built up over time and in some ways left the rest of us behind. And so I'll show you a little bit more schematically what I'm talking about. So message-based health communication is what we all learn, I think, in public health school, about how to and how we think that things really proceed when we have information to give to the public about a health issue. So it starts with scientists who are studying whatever the issue is. Maybe it's COVID-19, they're studying the disease. And once they have findings, that those go to scientific advisory panels, and they go to scientific journals and preprints where things are published, peer-reviewed and published. And then public health practitioners, which is all of us, most of us, this is where we come in, to really take those scientific findings and think about translating them to the public and how we're actually going to use those to create guidelines and information for public use. And healthcare workers and clinicians come in at this point as well. And then sometimes, there's also another intermediary here. Actually, very often there's another intermediary here, which is the media. and journalists who come in here and they take the information either directly from science and scientists and people at universities, or from clinicians and public health workers, and they, translate that really eventually for the public. So this is a very linear model of how health communication happens, and it's this message-based idea, which is that the message sort of stays intact and goes down this line, and eventually it gets to the public, and there's sort of no interruption. And of course, that's not what really happens anymore. We have in the middle this networked health communication, which is sort of happening everywhere, all across social media. And everyone is sort of surrounding these networks and interacting with them back and forth. But there's no sort of linearity here. There's no idea that the message comes from one source and then it's sort of passed down the line until it gets to the public. Instead, really what we have is that things have a great opportunity to get distorted and changed in this process, because there's so much back and forth among many people who, there are a lot of other ideas they have or motives they might have, as we talked about earlier, to change the information. So this is sort of what we're dealing with now versus what we think we're dealing with, which is what I just showed. So I did want to, before I get into talking about sort of the environmental health perspective, I would feel bad if I never talked about psychology, because this is really my first foray into this topic. And I think it's still really important for everyone to understand sort of what are the psychological predispositions that bring people to a point where they're more likely to believe in misinformation, and where they're more likely to deny scientific evidence. And so you can definitely, look at my book if you want a full discursus on this topic, but it really comes down to a few, these major topics, which I put on the slide here. So one is complexity and uncertainty. So we're dealing in a situation in health where, as you know, there's a lot of complexity and there's a lot of uncertainty. COVID-19 is obviously a prime example, but it happens in every field and at all points in time across the development of an illness, or a new epidemic, or whatever public health problem you can think of. There's often complexity and uncertainty, and people are fundamentally uncomfortable with that. They've come to expect that scientists and health practitioners will give them 100% certainty. And obviously we can't do that. So we always saying, oh, we're 95%, 90%, et cetera, certainty. And people think that that means that we don't know, or that we can't promise them something. And so they start to lose a little bit of trust and they get frustrated. So there's a huge disconnect there between the way science works and how it never gives us an 100% answer, and what public expectations are about how science should give them answers. Then there's risk perception, which I'm sure all of you have heard is completely skewed and really a psychological phenomenon, but we tend to treat it when we communicate risk as if it's a sort of straightforward, that people have sort of calculators in their mind where they can look at risk very straightforwardly. But really what happens is that people overestimate small risks, then they underestimate large risks often. And they also are much more afraid of things that seem familiar, like a plane crash, because they've seen it in the news and they can imagine it. And they're less worried about, or less risk perceptive of, things that really are, sort of everyday occurrences, but maybe big risks, like getting into a car accident. So risk perception as a concept is not straightforward for people. And also, everything that we talk about in health and medicine is really a trade-off, is a risk benefit. There's most of the things that we try to get people to think about have to be a trade-off. And that's very hard to introduce in a palatable way, especially when people's risk perception is so skewed. And then there's group membership. This was the point that was really important in the book, because a lot of the discussion about science denial was very individually based, and about, some of these concepts like risk perception and confirmation bias that occur within the individual. But what we really have to understand is that these conversations are happening in large groups and often online, and it's easier to join groups online than offline. So they're more common. And so once you're in a group, your ability to sort of think about risk and really assess evidence is compromised, because you think that the group has sort of decided all of these things already and that you don't have to look into it. And so then that becomes a real open door for people to fall into more misinformation. And then as I just mentioned, confirmation bias is still really important. The idea that you look for things that you already believe in and you sort of dismiss things that you don't believe in. And there's also this thing called the continued influence effect, which is when people have misinformation that's corrected, but they still believe the misinformation. Like they see that it's wrong, but they still continue to use the misinformation in their sort of thoughts and decision making. And there's a lot that we don't understand about why that happens. But some of it has to just do with the fact that sometimes the misinformation story that we're told is a little bit more palatable than when somebody says it's not due to that, but we don't know what it's due to. So vaccines are not causing autism, but we don't know what causes autism. That's very difficult because you haven't provided an alternative explanation. And so that creates a sort of a hole in the person's thinking, and they're psychologically inclined to keep believing the thing that gives them a fuller story. And then there's just a lot of unknowns in the psychological predisposition research. So there's a lot we still don't understand about how people process health information, how they make decisions, why they don't accept retractions of misinformation, like I just talked about. And there's still a lot of debate in the literature about how all of these things interact. So still something that we're also looking into, but definitely important to keep in mind the psychological part of this. Now, it's harder sometimes to intervene on some of these things because they're so entrenched. And so we do want to talk about another framework that focuses less on psychology and more on sort of environmental factors. So we like to look at misinformation coming from an environmental health approach. So if you'll just bear with me, I'll sort of explain to you the analogy a little bit. So all of you know what environmental health is. And that hopefully, there are sort of these three main concepts within environmental health that explain sort of what puts someone at risk for really developing a disease. And so predisposition, exposure, and access to mitigators. Now, this is a vast oversimplification, but these are sort of the mainstays of what we like to think about. So for example, a child's risk of getting asthma is a function of their individual immunological predisposition, various social determinants of health, allostatic load, their exposure to pollution and toxins, and then whether they have access to mitigators. So things like, do they have access to good healthcare? Do they have access to parks, trees, green spaces? So those three things are also, again, there's this lack of linearity here where these things interact with each other. And so the exposure and the predisposition can interact, and one, sort of goads the other and back and forth. So if we look at this in the misinformation space, so keeping these three elements in mind, then we get sort of a different set of questions and considerations than we had before. So when we're looking at exposure, how much exposure does a person have to toxic misinformation? Well, we have to first define what toxic misinformation is, which is sometimes difficult, but how big is the exposure, just like with environmental toxins? So that matters. If you see it once or twice, the misinformation, maybe that's okay. But if you're in an environment where misinformation is everywhere, it's really saturated with misinformation, then that's a big exposure, and that might be a different scenario. So we may not need to or want to intervene when there's just a few things floating around, but we may want to find the environment where there's tons of misinformation going to a certain group of people all the time. And then we may want to focus on that. And also it gets determined by media diet, which, by the way, is not totally self-chosen. There's kind of like a choice architecture there where people have access to certain news sources and don't have access to others based on their internet access and whether or not local media sources have died out where they live, which is a big problem now. So again, not totally unconstrained by the actual environment. News choices, social media use. So not just if they're on social media and what platforms they use, but how much social media matters to them. There are people who are on social media a lot, but they don't really care that much about it. But then there are people who really depend on it for their social communication and for their sense of identity in some ways. And so that person is maybe more at risk than someone who, when they see something on social media in one of their groups, believing it, than somebody who's sort of like, oh, I don't really care about social media. I just go on here because I'm bored. So that's important as well. And then what's one's predisposition to finding misinformation credible? So that's a lot of the things that I already talked about, the psychological predisposition. There's a lot of debate in the literature, and I just wrote an article about this actually, about are there certain characteristics that make people more prone to misinformation or believing in misinformation? And some studies find educated people, and some studies find uneducated people, women, men, old, young, liberal, conservative. It sort of goes back and forth which one. I think the one that is more consistent is that people over age 65 have a tendency to share more misinformation. I don't think we really know if they believe it more, but they may share it more. But other than that, it's not very clear sort of if there are certain demographics to who has a tendency to believe misinformation. But it's important to understand the common psychological factors that I just discussed, because that can, those are sort of some of the predispositions to believing misinformation. And also other social factors like being very isolated. In some cases in America, in certain places, sort of losing employment or aspects of identity that are particularly important to a person can predispose them to being more sort of prone to misinformation. Sorry, I'm hearing some background noise here. Okay. And then of course, access to mitigators. So this is just as important in misinformation environments as it is in asthma, as in the asthma example. And this is where the real structural questions are relevant. So how much access does someone have to a healthcare professional that they have time to talk to and that they actually trust to be able to get, answers to actual questions? How do they trust medical professions and public health officials? That there are some populations that trust medical doctors and public health professionals more, and others that trust them less. So that's important to understand as well. Do they have access to a broad array of media sources, or are they limited? Some of the factors that I discussed earlier, like internet access, local media, public media sources, the availability of those things are in part important for understanding whether people have access to mitigators. Okay, sorry. Okay, so these, again, as I said earlier, these elements work together and are constantly influencing each other. So again, there's no linearity in anything that we're talking about today. If you remember nothing else from the presentation, that's that we said everything influences everything else in kind of this cycle. And it's, and that's sort of part of the complexity. So why do we want to take an environmental health approach? What benefit does this give us? Well, it does allow us to sort of help us see that we can't completely eliminate misinformation on the internet. And that's where this comment comes in. I saw something wrong on the internet. I have to fix it. If we thought that was our job, we would be, we wouldn't be able to sleep. We wouldn't be able to do anything else. It would be impossible and overwhelming. And so we have to come to a place where we have a system that allows us to identify what are the most consequential sort of nodules of misinformation and where are they happening and where are the people most at risk, so that we know where to intervene with the most efficacy versus trying to just neutralize every single piece of misinformation that's on the internet, because that is not a sustainable path. And so the example here would be like, for example, lead. Lead is toxic in certain circumstances. So if you ingest lead as a 2-year-old, that's much different from rubbing a block of lead on your skin as an elderly person. So, it matters sort of what the context is. And then, this is the same thing. We tend not to think about the medium of misinformation enough, where it's different if it's a video or an image or a text. It's probably different, but we don't think about that context enough. We tend to treat all misinformation equally. So thinking about the context dependency and really focusing our interventions is part of the benefit of using this approach. And then there are sort of certain epidemiological concepts that are important here. So thinking about trust and how that differs from community to community, and trust in the public health professionals and the medical system. And then exposure to certain news sources. Again, there are sort of clusters of people who have better access to local and public news or better news sources than other people do. And so having a more systematic approach to that is also important. And probably the most important thing here, which, last but not least in this list is, equity, because all misinformation is not created equal. And for one thing, some people are targeted. So certain groups, like a lot of Black and Latinx groups in the US, get targeted by disinformation peddlers. And so that creates an exposure that might not exist for other people. There are also information deserts, just like, especially sort of in the age of the death of local news, where there are people who just don't have access to what's happening day to day in their local communities, and even a little bit, more broadly than that. And they don't have good access to healthy information. And so it's the same as how some people don't have good access to healthy food options at an affordable price. So your ability to question misinformation is then obviously compromised by your lack of exposure to high quality information. So the environment therefore matters very much in terms of whether you come to be able to, look at this in a more objective way. And then I would just put a few examples here of times and places in the history of public health with food regulation, water safety, antibiotics, and vaccines. So certain technologies and things that we've developed that have helped us be able to work in a more preventive manner. So instead of just sort of like drinking from the fire hose all day, where we're constantly responding to like, there's another crisis, and we can't get ahead of it, when we have these tools, we can. And what partially happened with the COVID-19 pandemic was that the infodemic came right on the heels of it, and we had no tools. We really weren't prepared to deal with that, and we had not been able to get in front of the situation by working on bolstering the information environments to be able to withstand this deluge of information and misinformation. And so that's what we really need to do, because, come the next crisis, we don't want to obviously be in this situation again. So what does that look like? So for one thing, we do think that certain regulations for social media are important. So working on algorithms and reducing algorithmic approaches that help people basically brainwash themselves with the internet, trying to avoid echo chambers. And also there is a really important place for building media and digital literacy. But as I said, that needs to happen continuously outside of when there's a crisis, and not just in the moment when something that won't work, when something is already going wrong. And then we need to focus on marginalized populations, like I was just saying, because they have, first of all, have historical reasons to distrust the public health and medical professions. And we have to make sure that that distrust is not being sort of leveraged to further sow more distrust, which is what happens with some of this disinformation peddling. So these all make for the beginnings of healthier information environments. But misinformation and disinformation will never be gone, no matter what else we do. So we still have to intervene. And so this is where our infodemiology interventions come in. But before I turn it over to Dave, I just wanted to see if there were any questions on this part of the presentation.
I've been answering a few in the chat
Great.
that have come up. Some of the ones that have been asked have been essentially, one was asking about the, there's a long history of misinformation being spread in around climate change and tobacco. And so kind of how we incorporate that into our model. And I mentioned how a lot of the evidence around kind of interventions to do with misinformation, including inoculation, rebuttals, appealing to scientific consensus, trusted sources, especially in-group sources, kind of has come a lot from the climate change literature. Less on the tobacco. Climate change has been an active area of misinformation studies for a long time.
Tobacco has been an area that's been studied in terms of motivational interviewing. So when you go into that, that is one area where it's been effective, and a few other areas of like sort of behavior change in public health as well. I would say the other area that a lot of the literature that we look at comes from is political misinformation and disinformation. So sometimes we do have to be cautious because the issues involved there and the psychological problems are a little bit different, and there's more identity, sort of issues in politics than in health. But there's a lot of crossover, and so that the political scientists have done some really excellent work on misinformation and disinformation.
There's another question about how various different types of literacy, like media literacy, health literacy, science literacy, some even talk about digital literacy, intersects with predispositions. Sara, is that something you'd want to tackle?
Yeah, so I can make sort of one comment on that. I think that, it's interesting. There's a big move toward incorporating digital literacy in teaching like high school kids and middle school kids, because obviously we want people to learn early sort of how to deal with understanding if a source is accurate, et cetera. But one of the problems that we confront here and that we think that should be, and we're trying to work on making this more part of the education environment, is again, that there isn't enough awareness among educators about some of the barriers that people might have to actually accepting these teachings. So I think that that's part of the work that still needs to be done, because without and again, that comes to sort of understanding like what are your students' information environments and what other things are influencing them and what are they entrenched in. I think that's part of the equation here to sort of figure out how do we really instill some of these practices in them in a way that's going to sort of stick. Do you have anything to add to that?
No, that sounds good. There's a lot of excellent questions here. Another one that I'd like to take, and I think we might be able to address some of them during the talk, or even kind of after the second half of the talk as well. But someone asked, why must the definition of misinformation be limited to what is known at the time? Damage can still be done even with the best info we have at the moment, such as early COVID statements on fomites. And I think we all think about the public health discussion around masks at the early part of the pandemic.
Yeah. Yeah. No, do you want to?
The thing that I would first mention is there is a lot of debate about how to define misinformation because it's so context dependent. And I think this folds into our argument because I find this somewhat similar to trying to define toxin, because what is a toxin depends highly on context. I don't know if any of you are clinicians, but I often say that I admit a number of people to the hospital with low sodium because they drank too much water. Water is literally part and parcel to life, but in very high doses, it can be toxic. And so one of the things that we have to recognize when we're dealing with misinformation is that whether or not even truthful statements taken out of context and put in certain environments can actually be highly detrimental and toxic. And so we need to understand the contextual factors. And that's why it's not always fruitful to be looking very specifically at a message, right? Is this sentence misinformation? Is somewhat like asking, is water a toxin, right? And it's like, well, it depends. And so I think we need to be focusing less on the definition and any specific bit of misinformation, more on the context. So I don't know if you have anything to add to that.
Not really. I think that's great. I mean, I think there's a whole discussion about how to communicate when there might be more information later that contradicts what you're saying, and that's really relevant to a epidemic situation. So that's kind of a separate topic, but I think what you said is about the context is important.
All right. So there's some excellent questions in the chat, and we'll definitely either answer them via text, or while we hopefully in the second part of the presentation, we'll be able to answer some, and we'll definitely take more questions at the end. I'll share my screen. What I'm going to be talking about is responses. And one thing I will say at the start of this is, relatively speaking, there's very few. There's much more research on essentially the surveillance of misinformation. What is misinformation? And very kind of micro studies on what might be done to address very specific bits of misinformation. But when we're thinking about this overall response that I think a lot of public health practitioners are facing, and some people in the questions mentioned, we're dealing with a lot of vaccine hesitancy in rural areas. Like, this is a situation. How do we respond to this situation? We're not trying to respond to one specific bit of misinformation. That's what I'd like to get into now. So I'd like to bring up this article that was recently published in the New England Journal of Medicine Catalyst, written by a number of people who worked for the New York City Department of Public Health during the pandemic at the very start, and also responding to the infodemic of anti-vaccine misinformation. And I want to specifically point out the title, that they argue that combating misinformation is a core function of public health. I highly recommend this article because they detail a number of different aspects, including surveillance, community-oriented responses, especially kind of bilateral, kind of a feedback mechanism between the public health department and the community, so they could understand what misinformation is circulating and respond to it as quickly as possible. And then just trying to iterate on that using essentially plan, do, study, act cycles. I think it's one of the best examples that we have so far of trying in real time to develop a system and combat misinformation.
Dave, we don't see your screen. I just wanted you to know that.
Oh, thank you. I don't know why that's the case. There we go. Let me, sorry about that. Thank you. So this was that public health article that I was mentioning. Other initiatives have been the NIH Community Engagement Alliance, the SEAL program against COVID-19 disparities. This is a program that was developed in 21 different states that aims to bring together communication professionals, public health professionals, and experts, as well as partnering with community-based organizations, specifically to try to address knowledge gaps and misinformation about COVID-19 vaccines. And their goal was essentially to provide accurate information, to provide educational tools, to host events in the community, to answer any questions, and listen, engage, and partner with the community to be able to respond quickly to any misinformation that was circulating. So this is another excellent example of community-based methods to try to address not just any specific bit of misinformation, but the larger overall sense of mistrust, kind of some of the underlying reasons for why misinformation might be able to take hold within a community.
That's important.
Another example is some of you guys might be aware of the This Is Our Shot program, which has also kind of manifested in Spanish as Vacúnate Ya. There's also the IMPACT, the Illinois Medical Professionals Action Collaborative Team, which is a group out of Illinois. All of these groups are made up of healthcare professionals. And what these groups have essentially tried to do is they're trying to say that vaccines are in our lane as healthcare professionals and leverage the trust that the vast majority of Americans say that they have in healthcare professionals, and use that expertise and authority to encourage people in online settings to get vaccinated. And the beauty of this is there was a very kind of groundswell of support among physicians and other clinicians that were interested in trying to address misinformation to create this movement, as well as Impact in Illinois kind of did this as well in their local communities, and pushback in online areas like Facebook, Twitter, Instagram, to try to address misinformation about vaccines and try to build vaccine confidence. In these different examples, New York City, the SEAL program, and some of these provider-based programs, there are some limitations. And I do want to emphasize that these are rare examples of interventions to try to address this problem. So I would say these limitations are small in comparison to the overall benefit that they're trying to bring, even just by trying to iterate in this space. One of the challenges that we face is there's the burnout is very easy to come by because there's a bit of a whack-a-mole feeling that we have. You can imagine what it might have been like to be an epidemiologist in the early 1700s, where there was constant outbreaks of cholera, smallpox, diphtheria, whooping cough, and any number of epidemic diseases. Very much would have felt like a whack-a-mole approach. We're in a similar situation right now with misinformation. The environment is so toxic that we're constantly facing kind of surges of infodemics all the time that for public health professionals becomes a serious challenge. They're also trying to move from that unidirectional model of communication that Sara described earlier in this presentation, kind of top down from scientists and experts and public health professionals, essentially down to the public in this hierarchical model of communication, very message focused, and trying to create a much faster bi-directional communication, which I think is absolutely an improvement on that initial kind of very message focused top down model, but still doesn't quite match the architecture of our information environments, where information consumers have become information producers. In a networked information environment where everyone's talking to each other, bidirectional communication is an improvement, but we're not yet quite commensurate with the structure of our information environments. There's also, because of these two things, it raises questions of sustainability. The New York City Department of Public Health doesn't quite have the same response pattern to addressing misinformation now that they did during the pandemic, simply because the funds required to sustain that are very challenging. The SEAL team program is fantastic, but I constantly hear things back and forth about whether or not the NIH is going to be able to maintain funding for these programs. Vacunate Ja and This Is Our Shot and the Impact program, wonderful groundswells of a lot of kind of enthusiastic support, but were essentially entirely volunteer-based. And so that groundswell fell off very quickly, raising questions about how sustainable such peer support networks might be. There's also a focus a little bit on kind of the knowledge deficit model, which, as Sara pointed out, a knowledge deficit is only one component of this. And so the SEAL teams, for example, do an excellent job of finding out what concerns and what questions communities have. But it's more challenging in situations where people are trying to make decisions under uncertainty. And we don't yet really have a robust model for helping to guide people make decisions under uncertainty. These programs that I described are fantastic when we have knowledge that scientists have some consensus that we're able to provide expert knowledge and consensus and guidelines. And then those can be communicated in community appropriate ways. But when there's a lot of uncertainty, it's much more challenging. There's also a challenge with the fact that a lot of these programs are focusing on what public health professionals you may have heard described as the movable middle. These are the people that we feel can be swayed. But there's a sizable chunk, somewhere between 1/6 and 1/5 of the population, that essentially say they won't take a COVID vaccine under any circumstances. And on any issue, there's this really immovable skeptic group. And a lot of these models that we're talking about just essentially almost write that group off of say, well, we'll get more bang for our buck on the movable middle, and we're not quite sure what to do about this. Now, again, I don't want to criticize these other, I think there's a lot of work that can be done, and these groups have done a lot of fantastic work to lay the groundwork for where we need to go in this space. But these are some things that I think we need to be thinking about as we go forward. So as we talk about this, our goal is to try to maximize exposure to healthy information. So what are some ways to do that? One is adjustment of algorithms, and I'll talk about how Google has been trying to do that. Then there's screening for information environments at the point of care, like we do for other social determinants of health, and I'll mention this as well, we can also start thinking about risk stratification, both by stratifying which populations are most at risk for finding misinformation credible, and then also what are the virulent pathogens that are out there? What is the misinformation that's most likely to go viral or most likely to be psychologically sticky? Finally, I'm going to talk about the intervention that we've been developing with infodemiologists. So some of you might not have heard of this, but this is one of the few times that you will hear someone giving a webinar to recommend that you take out your phone and go to YouTube. But if you do, and you search for a health topic like diabetes, you may notice that the search results that come up are prioritized. And they actually have figured out a mechanism to prioritize credible health sources. Now, Google didn't decide what the credible health sources were. But what they did is they knew that this was a problem, so reached out to the National Academies of Medicine, who worked with the World Health Organization to convene a committee to describe what are the principles of highly credible organizations working in this space, so that they can be prioritized. And so you'll see on YouTube, in the YouTube app, that they prioritize information from hospitals, from clinics, sources that we all would agree kind of meet the principles that you can find on the National Academy of Medicine website. So this is an important step to make sure that when someone's searching for something, the first results that come up aren't necessarily an ad, aren't necessarily the things that are going to get the most engagement, but are the things that are actually going to lead to a healthier information environment. There's also things that we can do to screen for information environments at the point of care. Even having I'm not necessarily saying kind of clinicians need to do this, but just like we screen for food insecurity, just like we screen for housing insecurity, we can screen for where do you get your health information? We can ask questions like, how do you decide who or what is trustworthy? And how do you sort between good or bad information? And people who somewhat screen positive of either not having trusted sources or not really being able to identify what trusted sources are, can then have some degree of an intervention so that we can talk about kind of and understand what their predisposition is, what toxic exposures they might have to misinformation, and what access they might have or not have to quality health information. And these are people that we might prioritize to come back to clinic to give them access at least to a trusted source. So I do think there's things that we can do at the point of care to be screening for essentially low integrity information environments and start to begin the process of building robust information environments, at least by bringing people back to clinics so they have access to trusted experts. This is some of the work that we did on this. We wrote an opinion piece about this. Next, I'd like to talk a little bit about some of what we can do to stratify and risk stratify populations, because we often take census data and think about risk stratification based on very typical categories. We often think about marginalized, underrepresented groups, usually based on some of these census categories that you see here. But so this example that I pulled from Sergo Ventures is what they did when they were looking at COVID vaccine hesitancy. They did what they called psychobehavioral segmentation. And they found that if you actually do surveys and try to understand where people are, then you can understand that people spread out along a spectrum of vaccine hesitancy, from enthusiasts all the way to the COVID skeptics. And they found ways that they could focus on the folks in the middle, the persuadable 43% that they say. Now, I will say that there's not a consensus on what type of psychobehavioral segmentation we need to do. There is an emerging consensus that we need to do psychobehavioral segmentation. So I think that's a really important point, that we can't just rely on traditional census categories, but we need to be thinking about which populations psychobehaviorally are along this spectrum and might need more intervention. There's other things that we can do to assess the risk based on specific types of misinformation. So our colleagues at the University of Pennsylvania have developed a category system for which they can code claims about infectious diseases. And they developed a 10-category system for anti-vaccine claims about the COVID vaccines. And they did a lot of work on this. And I won't go into the details of all of these specific categories, but I'm using this as an example of through all of this research that they did, they found that the categories of information that rose to the top were issues about vaccine safety. In particular, issues about vaccines that were, whenever it talked about fertility, or if it talked about changing someone's genetics. So once we start to know kind of what pieces of misinformation are the most virulent, we can start to try to address those. There's also certain mediums, right? I think we can all remember the Plandemic documentary that came out and how that really kind of caught fire because it seemed to kind of just, even the title of it was so memorable. But we can start to identify what might make certain pieces of misinformation a little bit more psychologically sticky or have greater chance of going viral. And these are things that we should be, based on risk analysis, trying to focus our efforts, our attention, and our resources. So our work at Critica has been focusing on infodemiologists that we perceive as first responders to the infodemic. An infodemiologist we see as akin to an epidemiologist, because if epidemiologists respond to epidemics, infodemiologists respond to infodemics. And they do that using a number of the different techniques that you see at the bottom of your screen: motivational interviewing, inoculation, using personal narratives, community trusted sources, evidence-based rebuttals, reinforcing self-efficacy, and repetition of high quality information. A lot of the evidence basis for this came from working to try to address climate change, work from political science on political misinformation. And the way our infodemiologists work is they come from the communities in which they intervene. They're seeing what conversations happen in online spaces. They see sometimes the vitriol and the anger, and they're engaging with empathy using evidence-based communication techniques to try to engage people in particular ways based on motivational interviewing principles, not necessarily to try to twist their arm or reach a conclusion or even convince them to get vaccinated. But really the goal is to improve information environments and try to help people move along the stages of change, even from some people who are pre-contemplative, moving them to contemplative, moving contemplative people closer to action. This is the goal of the interactions that we're trying to have. So infodemiologists, we argue, are field epidemiologists for infodemic response. And like field epidemiologists, if you think of the EIS officers at the Centers for Disease Control, they are part-time, they are community embedded. So these are people that we want to be existing within communities, to know their communities really well, to know the values, the perspectives, the identities of those communities, to be able to speak to those. And they do that using a technique that we call community-oriented motivational interviewing, which I'll go into a little bit more detail about shortly. We also see that infodemiologists need to be connected, both vertically within the public health system. And this is that bi-directional communication that I was talking about, that the SEAL teams have, the New York City Department of Public Health had. But we also find that infodemiologists need to be horizontally connected, in the sense that an infodemiologist in one community needs to be connected to infodemiologists in other communities so that they can share best practices and they can share information about what is spreading in their community, or what techniques or what rebuttal techniques or what discussion techniques seem to work best in their community, so that people might be able to adapt those techniques to the community that they live in. We also see this a little bit in the CPR model, in the sense that 50 years ago, only physicians really knew CPR. Now, everyone that works at my son's daycare knows CPR. I sincerely hope that they never have to use it, but the goal is that we have enough people trained throughout our society so that we're able to call upon these skills as necessary. And so not necessarily everyone needs the kind of the gold-plated training that we do for our infodemiologists that takes a number of hours, but there's a number of different trainings that we can do, essentially a BLS type of training to try to spread the word about infodemiology so that people know at least the basic tenets of it. Who can be infodemiologists? Healthcare workers absolutely can be infodemiologists. Specialist societies like Berkeley alumni absolutely can be infodemiologists. Trusted community leaders we see as playing a key role as infodemiologists. And any of you, I think, have the potential to be infodemiologists as well. So community-oriented motivational interviewing. What does that look like when we're trying to practice that in online settings? And for people who are more interested in the details of this, I refer you to the paper at the bottom that we recently published in Computers and Human Behavior. but our focus is on a community's information environment. We're not necessarily just trying to, play whack-a-mole with every bit of misinformation that's on the internet. That's not our goal. We're trying to understand what misinformation is circulating in a particular community, and based on that, have thresholds for intervening. Sometimes that's at the level of a specific bit of misinformation, but more often that's a little bit of what are recurrent themes that keep coming up. Is it safety? Is it distrust? And these are the things that we're trying to address to get at the underlying issue rather than the specific bit of misinformation. Our focus is on the whole community, not just on the movable middle. One of the things that we try to do is we try to step back, and by looking at the bigger picture, what's the underlying concern? And we think about and have our infodemiologists reflect on what are the underlying values of the community? What are the ways that we can talk about this that are commensurate with the values of the community, so that we can have a way that isn't just speaking to the movable middle? Because if you only speak to the movable middle, there's a decent chance that you might actually further alienate those skeptics that are on the side. So are there ways that we can speak to the whole community as a whole? These are techniques that have been developed through adapting motivational interviewing to groups, to couples. So these are techniques that we're trying to bring into our adaptation of motivational interviewing. One of the ways that we do this is by activating bystanders, because we're not the only people in these environments. We draw from some of the literature on hate speech and counter speech to try to figure out ways to activate a number of the silent people that are just observers online and bring them into the conversation. But because we can't control what they say, one of the things that we have to be very careful about is trying to reframe any information that bystanders or other people bring into the conversation according to the community's identity and their values. So for example, when people say like, oh, I don't want to get vaccines because that takes away my freedom, we can start talking about, well, I actually think that the vaccines gave us our freedom, right? The vaccines was one of the most important things to help us try to get to an endemic stage of this pandemic. So reframing information so it doesn't conflict with our values, but it's actually commensurate with our values, is something that we train our infodemiologists to do. And finally, the infodemiologists recognizing that there's a lot of uncertainty in any decision that we're making. Even in situations where there's scientific consensus, there's always some question that can come up where there's a lot of uncertainty, where we have to have thresholds for how we weigh kind of the risk to an individual versus the benefit to a community. And making decisions amidst that uncertainty is value-based. And so it needs to come from the community. So our infodemiologists who come from this community can talk about how they made some of these decisions and how they weighed some of these risks that are very, very community and value embedded. So our goal is to try to think about this architecture of networked health communication and think about how infodemiologists could fit at the center of it. Because ultimately the goal is to take the network model that we saw here and try to take that Madagascar-like island of public health professionals in green over on the side and bring them into the center of this network so that they could be part of the conversation. So with that, Sarah, I don't know if you'd like to mention a little bit about kind of what we offer for our trainings.
Yeah, so like I said before, we do trainings, but we also do technical assistance for, say, health departments or organizations that are dealing with overwhelmed or overwhelming information environments. So that sort of includes the ability to diagnose what's going on in the information environment using some of the principles we discussed tonight, as well as to provide training for people to practice the infodemiology intervention, in the case that that's the best situation, or other strategies that we can also train on that are, evidence-based strategies to fight misinformation. So that is something that we offer, especially to health departments, but to other organizations as well. And for clinicians, so helping with implementing better behavior change methods, that's a big part of our work that we didn't get to talk about a lot tonight. And also dealing with misinformation at the point of care to the extent that a physician has time to do that. That's really important as well.
And with that, thank you very much. Just want to leave you with the public health message, which says in Arabic, an ounce of prevention is worth a pound of cure, which I think hopefully resonates with a lot of public health professionals. And with that, I'll stop sharing my screen and we're happy to discuss some questions.
Do we have time for me to ask Dave a few more questions?
Sure.
Yeah, okay. So there were a couple of questions about the social media companies and how they should be involved with this. And also there was an interesting question about the layoffs and, you know, how that might affect any work they may have already been doing around moderation and algorithms and et cetera.
It's a little bit of a black box in the sense that there's a lot of discussion right now about content moderation by social media companies. They all have policies. Anyone that's interested in this, I recommend there's a fantastic report by the Stanford Internet Observatory that looks at memes and magnets and talks. I'll see if I can find the link and perhaps we can send it out. But it talks about what are the different policies that social media companies have with respect to aspects of misinformation, taking down hate speech, different things like that, and how consistent they are at actually taking it down. And they tend to be pretty inconsistent, number one. And number two, they're absolutely atrocious in languages that are not English. And so we're talking about the misinformation problem in English, and I think we're only scratching the surface because there's actually a lot of things that the social media companies are doing in English. And I don't think we're really seeing just how bad it is in a lot of other languages.
Great point. Another kind of techie question. How might the rise of ChatGPT influence the spread of misinformation versus factual information? I mean, my only response to that is generally just fear about what's going to happen, but I don't know if you have more insight.
My thought is, so I talked to an AI expert on this, and the way he described it is that the part of the problem is that ChatGPT hallucinates facts. When it doesn't know something, it doesn't say it, and it just makes it up. That's clearly a problem. AI is trying to get better at that. The other thing that I would say is part of the challenge of why is misinformation a problem now, where it wasn't 30 years ago, right? It's always existed, but why did we not care about it 30 years ago? And suddenly it's a big issue now is the speed and the scale at which it travels. And the challenge that I see with ChatGPT is it's not really going to change the speed because the speed is driven by the internet, but it's going to change the scale because the ability to produce misinformation at low cost has just gone up dramatically. So that's what has me most concerned.
Let's see, there might be a new question. Yeah, maybe we should try interrogating ChatGPT. That's a good point about around health misinformation and see what happens.
I've done a little bit of that, and it has a lot of the evidence base of but things related to inoculation and rebuttal and climate change. But when it doesn't know something, it just makes it up. And the challenge of that is you really have to be an expert to know when it's just making something up versus when it really is kind of drawing from the evidence. I find it kind of scary sometimes.
Yeah. There was one more question I wanted to mention about sort of how trust has developed over many experiences, not just one transaction. So, and that's true that a lot of COVID messages were sort of like one message and then you had no one to interact with. So that's partially why we like to do our interventions that are conversations, but we also recognize that, you know, sometimes there's a need for more than one conversation. And so, you know, we definitely want to look into ways to continue that past an initial encounter, but definitely having the conversation is better than the one-way communication for trust building. So I think those were the main questions that we haven't already answered, or I see you're typing in some responses, Dave. So
I want to thank Dave and Sarah. This was a very eye-opening and very thought-provoking kind of paradigm to think about misinformation, because, you know, previously it was just like, this is coming from social media, it's coming from a certain population, it's coming from, you know, a certain political party potentially, but now, you know, we're stepping back and looking at as an environment, exposure, looking at determinants of health, you know, the environmental aspects and context. So that's very helpful, especially for like public health professionals and clinicians like myself, to look at this frame and approach it in that frame, and reassessing like, oh, where do you get your information? What are, and do you have any questions, rather than coming at it from like, that's false. This is like, science is, bounded by evidence, and having it a debate that may not realize the context and where patients get information. So, and I do appreciate the community model that you mentioned, because the lived experience and the peer network and where people get information, usually it's through a trusted source. So if we influence the trusted source and start from a community-based model rather than, these outsiders, the doctors, these scientists, they're not even from here, but giving them a more community-based participatory approach, I find that really helpful, because in HIV, especially in marginalized communities, a lot of the stigma and misinformation about HIV and what it did to the body and access to treatment, a lot of the paradigms and shifts were, grounded in the community addressing the misinformation. So I really appreciate your time and your amazing way to frame how we should approach misinformation in the future.
Thanks for having us. Great to be here.
Thank you.
Thank you. And for the audience, we're going to have this webinar, recorded, available on YouTube. If you want to share it with your colleagues or rewatch it again, it'll be ready for caption. And if you have any further questions, please do let our Public Health Alumni Association know. We'll try to, communicate with the speakers for follow-up. Alice, do you have any closing remarks?
Oh, thank you so much. And we hope our audience have some key takeaways that we could use immediately. Thank you.
Thank you,
Thank you.
everyone.
Thank you.